Hello everybody. Today we are going to discuss guidelines of ARDS which are based on the European Society of Intensive Care Medicine. So according to the new definition of ARDS, these time of onset up to 7 days from known risk factor. Then there should be pulmonary edema which is not explained by cardiogenic edema or intravascular volume overload. Then regarding radiological feature, bilateral infiltrate should be there either on X-ray or CT, which are not explained by lung nodule, pleural effusion, and atelectasis. Then depending upon the PF ratio and SpO2 FO2 ratio, the ARDS is classified into three categories, that is mild, moderate, and severe. The mild ARDS is defined as with PF ratio of 200 to 300. With the NIV and the CPAP with PEEP of more than or equal to 5, and requirement of high flow nasal cannula should be more than or equal to more than 30 liter per minute. For moderate ARDS, the PF ratio should be between 100 to 200 with PEEP of more than or equal to 5. In case of severe ARDS, the PF ratio should be less than or equal to 100 with the PEEP of more than or equal to 5. Intubation is not required, is not required. Then regarding SpO2 FiO2 ratio, it should be less than 315 with SpO2 of less than 97%. Then a phenotype is the clinically observable set of traits resulting from the interaction of genotype and environmental exposure. So that is the ARDS phenotype. A subgroup is the subset of the patient within the phenotype, which may be defined using any cutoff in a variable. This cutoff can be arbitrary, and frequently patients fall just on the either side of it, resulting in patient switching subgroup. A subphenotype is the distinct subgroup that can be reliably discriminated from the other subgroup based on the set or patterns of observable and measurable properties. An endotype is the subtype with distinct functional and pathological mechanism which preferably respond differently to targeted therapy. So what is the evidence for the heterogeneity of the treatment effect between subphenotypes? So does subphenotyping alter the response, patient's response to anti-inflammatory intervention in ARDS? In secondary analysis of ARDS trial, patients with hyperinflammatory subphenotype seem to benefit from simvastatin, although the interaction term from heterogeneity of the treatment effect was not statistically significant. In secondary analysis of the SAILS trial, no heterogeneity of the treatment effect was identified for hypoinflammatory and hyperinflammatory subphenotype and treatment with the rosuvastatin. In a clustering reanalysis of SAILS trial, 4 subtypes were described, in which one group is defined by a high platelet and low creatinine, seem to benefit from rosuvastatin. However, these subphenotypes have not been reproduced in other populations. So does subphenotyping alter the patient response to the PEEP intervention in the ARDS? In secondary analysis of alveolar trial, identified heterogeneity of the treatment effect between hypoinflammatory and the hyperinflammatory subphenotypes in the PEEP strategy adopted. A secondary analysis of the observational lung SAFE study identified the similar pattern in that patient with hyperinflammatory subphenotype seemed to benefit from higher PEEP in contrast to hyperinflammatory subphenotype. In the LEAVE trial described above, a personalized PEEP and the prone positioning strategy based on diffuse versus focal radiological subphenotype achieved reduction in 90-day mortality when considering pre-protocol per protocol treated patient. So does subphenotyping alter the patient response to the fluid strategy? A secondary analysis of the fact identified the heterogeneity of treatment effect in that patient with hyperinflammatory subphenotype seemed to benefit from the liberal fluid strategy in contrast to the hypoinflammatory subphenotype. So how does subphenotyping relate to the patient outcome? Systemic inflammatory response judged by plasma protein, higher mortality in hyperinflammatory than in the hypoinflammatory. Then lung morphology, lung radiologic morphology, higher mortality in non-focal than in focal. Then regarding recruitability, higher mortality is seen in recruitable than in non-recruitable. Then regarding clinical features, higher mortality with more organ failure or comorbidities or acidosis. Then regarding longitudinal changes in respiratory parameter, higher mortality is seen in upward trajectory of ventilator ratio and mechanical power than in the steady trajectory. In non-mechanically ventilated patient with acute hypoxemic respiratory failure, not due to cardiogenic pulmonary edema and the acute exacerbation of the chronic obstructive disease, does high flow nasal cannula compared to the conventional oxygen therapy reduce the mortality or admission. So guidelines recommended that non-mechanically ventilated patient with acute hypoxemic respiratory failure, not due to cardiogenic pulmonary edema or acute exacerbation of COPD, receive high flow nasal oxygenation as compared to conventional oxygen therapy to reduce risk of intubation. But guidelines are unable to make recommendation for or against the use of high flow nasal oxygenation over conventional oxygen therapy to reduce the mortality. And it has no recommendation and high level of evidence. So this recommendation also applies to acute hypoxemic respiratory failure from COVID-19. It has strong recommendation in the low level of the evidence in favor of intubation and moderate level of evidence of no effect for mortality. In non-mechanically ventilated patient with acute hypoxemic respiratory failure, not due to cardiogenic pulmonary edema or acute exacerbation of COPD, does high flow nasal oxygenation compared to NIV reduce the mortality or intubation? So guidelines are unable to make recommendation for or against the use of high flow nasal oxygenation compared to CPAP or NIV to reduce intubation or mortality in the treatment of unselected patients with acute hypoxemic respiratory failure not due to cardiogenic pulmonary edema or acute exacerbation of the COPD. So guidelines such as CPAP or NIV can be considered instead of high flow nasal oxygenation in the treatment of acute hypoxemic respiratory failure due to COVID-19 to reduce the risk of intubation. But no recommendation can be made of whether CPAP or NIV can decrease the mortality against the compared to high flow nasal oxygenation in COVID-19. So in non-mechanically ventilated patient with acute hypoxemic respiratory failure, not due to cardiogenic pulmonary edema, obesity, hyperventilation, or acute exacerbation of COPD, does CPAP or NIV as compared to conventional oxygen therapy reduce the mortality or intubation? So guidelines are unable to make recommendation for or against the use of CPAP or NIV compared to conventional oxygen therapy for treatment of acute hypoxemic respiratory failure to prevent mortality or to prevent intubation. It has no recommendation. So guidelines suggest the use of CPAP over conventional oxygen therapy to reduce intubation in patients with acute hypoxemic respiratory failure due to COVID-19. It has weak recommendation, and the guidelines are unable to make recommendation for or against the use of CPAP over conventional oxygen therapy to reduce the mortality, and it has a no recommendation. In patients being treated with CPAP or NIV for acute hypoxemic respiratory failure, does the use of helmet interface as compared to the face mask reduce the intubation or mortality? So the guidelines are unable to make recommendation for or against the use of helmet interface for CPAP or NIV compared to face mask to prevent intubation or reduce the mortality in acute hypoxemic respiratory failure. This treatment has no recommendation and low level of evidence. And the guidelines are also unable to make recommendation for or against the use of NIV compared to CPAP for treatment of acute hypoxemic respiratory failure. In patients with ARDS and COVID-19 related ARDS, thus the low tidal volume ventilation alone, compared with more traditional approaches to ventilation, decreases the mortality. So guidelines recommended the use of low tidal volume ventilation strategy, that is 4 to 8 ml per kg of predicted body weight, compared to larger tidal volume to reduce the mortality in patients with ARDS but not due to COVID-19. It has a strong recommendation based on expert opinion despite the lack of statistical significance. This recommendation applies to COVID-19. This recommendation also applies to ARDS from COVID-19 and it carries the strong recommendation and moderate level of evidence. In patients with ARDS undergoing invasive mechanical ventilation, thus the routine PEEP titration using a high PEEP or FiO2 strategy compared to lower PEEP FiO2 strategy reduce the mortality. So guidelines are unable to make recommendation for or against the PEEP titration with higher PEEP FiO2 strategy versus lower PEEP FiO2 strategy to reduce the mortality in patients with ARDS. And it has no recommendation and high level of evidence of no effect. This statement also applies to ARDS from COVID-19. It has no recommendation and moderate level of evidence. In patients with ARDS undergoing invasive mechanical ventilation, thus routine PEEP titration based principally on respiratory mechanics compared to PEEP titration based principally on standardized PEEP FiO2 table reduce the mortality. So guidelines are unable to make recommendation for or against the PEEP titration guided principally by respiratory mechanics compared to PEEP titration based principally on PEEP FiO2 strategy to reduce the mortality in patients with ARDS. It has no recommendation and high level of evidence. This statement applies also to ARDS from COVID-19 and it carries no recommendation and moderate level of evidence for indirects. In patients with undergoing invasive mechanical ventilation, does the use of prolonged high pressure recruitment maneuver compared to not using prolonged high pressure recruitment maneuver reduce the mortality? So guideline recommended against the use of prolonged high pressure recruitment maneuver, that is defined as airway pressure maintained more than or equal to 35 for at least 1 minute to reduce the mortality of patient with ARDS. And it has a strong recommendation. So this recommendation also applies to ARDS from COVID-19. In patients with ARDS undergoing invasive mechanical ventilation, does the routine use of brief high pressure recruitment maneuver compared to the use of brief high pressure recruitment maneuver reduce the mortality? So guidelines recommended the routine use of brief high pressure is defined as airway pressure maintained for more than or equal to 35 of less than 1 minute to reduce the mortality in patient with ARDS, and it has a weak recommendation. This suggestion also applies also to the ARDS from COVID-19, and it also has the weak recommendation and moderate level of evidence of no effect of the indirects. So in patient with the ARDS, does the prone position compared to supine position reduce the mortality? So guideline recommended the using prone position as compared to supine position for patients with moderate to severe ARDS, which is defined as PF ratio of less than 150 with the PEEP of more than or equal to 5, despite optimization of the ventilatory setting, to reduce the mortality. It has a strong recommendation. This recommendation also applies to ARDS from COVID-19. In patients with the moderate to severe ARDS, when should prone positioning be started to reduce the mortality? The guideline recommended starting the prone position in patient with ARDS receiving invasive mechanical ventilation early after intubation, after period of stabilization during which low tidal volume is applied and PEEP adjusted and at the end of which PF ratio remains less than 150 and proning should be applied for prolonged session, that is 16 consecutive hours or more, to reduce the mortality. It has a strong recommendation and high level of evidence. This recommendation also applies to the ARDS from COVID-19. It has strong recommendation and moderate level of evidence. In non-intubated patient with acute hypoxic respiratory failure, does awake prone position compared to supine position reduces the intubation mortality. So we suggest awake prone positioning as compared to supine position for non-intubated patient with COVID-19 related to acute hypoxemic respiratory failure to reduce the intubation. And it carries the weak recommendation, low level of evidence. So against the guideline are unable to make recommendation for or against awake prone position for non-intubated patient with COVID-19 related acute hypoxemic respiratory failure to reduce the mortality. And it has no recommendation. Also, guidelines are unable to make recommendation for or against awake prone positioning for patient with acute hypoxic respiratory failure, not due to COVID-19. So, does the routine use of continuous infusion of neuromuscular blocking agent in patient with moderate to severe ARDS, not due to COVID-19, or moderate to severe ARDS due to COVID-19 reduces the mortality? So guidelines recommended against the use of continuous infusion of neuromuscular blocking agent to reduce the mortality in patients with the moderate to severe ARDS not due to COVID-19 and also due to COVID-19. Uh, it, uh, if the in case of moderate to severe ARDS, which is not caused because of the COVID-19, it has a strong recommendation, and if it is caused by the COVID-19, then it has no recommendation. So, in adult patient with severe acute respiratory distress syndrome or COVID-19, does VV-ECMO compared to the conventional ventilation improve the outcomes? So, guidelines recommended that the patient with severe ARDS not due to COVID-19 defined by EOLIA trial eligibility criteria should be treated with ECMO in the ECMO center, which meet defined organization standard adhering to the management strategy similar to that used in the EOLIA trial, and it has a strong recommendation. This recommendation also applies to the patient with severe ARDS due to COVID-19. It also has strong recommendation, low level of evidence. So regarding regarding the use of EPO, the guidelines against the use of EPO for removal for the treatment of ARDS not due to COVID-19 to prevent mortality outside the randomized control trial, and it has strong recommendation. This recommendation applies also to the patient with severe ARDS due to COVID-19. It also has strong recommendation and moderate level of evidence of no effect for indirects. Thank you, guys.